What's going on, guys? I know I don't usually do intros like this, but I did a little bit of digging and I saw that the majority of people that watch this channel, 60% of the people that watch this channel, aren't subscribed to the channel. You can tell by just this production. It's going to look a little different than the video that you're about to watch. I know you're here for a medical lecture. I've been spending a lot of money, a lot of time trying to make the production better for you, for the viewer, for the student, for the paramedic or EMT. I want to know a little bit about you. I want to know, are you in school? Are you studying for the National Registry? Are you done with that? Or maybe you already work for an agency and this is just a review. I'm just interested. What brings you here? Let me know in the comments. Now, if you could do me a favor, I know I've been putting out a lot of videos. I'm going to continue to put out a lot of videos. I promise that to you as the viewer. I have a goal set for Rescue Academy. I have a lot of big things coming. If you could please do me the favor and subscribe, like videos that I share, that helps the algorithm promote it. Now, I know my 12 lead video, I announced my book coming out. Wait till the end of this one. I have more to talk about. Enjoy the lecture.
Jumping into cardiac meds. We're looking at beta blocker toxicity, which is an interesting one. First thing that I want you to know is, what is a beta blocker? Whenever we say beta, we're talking about either beta 1 or are we talking about beta 2? Because beta 1 has to do with your heart. Beta 2 has to do with your lungs. Whenever somebody's taking a beta blocker, what they're doing is they're trying to block beta 1. What happens with these patients and why they're typically taking beta blockers is it could be from hypertension. Could be their doctor decided to give them some sort of beta blocker to slow down their heart because their heart was working too hard. Maybe these patients have some sort of heart failure and they're trying to reduce the amount of oxygen demand that their heart has. Beta blockers are just slowing down the heart. That's what they do, man. It's interesting too to think that beta blockers actually get used in sports. You look at archery, for example. People take beta blockers to really slow themselves down. So when they're drawing the bow, they don't shake as much. They're a lot more alert. They're a lot more steady with their hands. Beta blockers just slow everything down. Talking about how these patients are going to present if they are on beta blocker, if they have a beta blocker overdose, obviously beta blockers are used to slow down their heart rate or trying to lower their cardiac output. If they take too much, we're going to see bradycardia. We're going to see hypotension. If I see somebody that's got bradycardia, I'm automatically assuming that this patient's going to be hypotensive, right? Because bradycardia is abnormal for most people. Now, obviously, I'm going to ask them, hey, man, do you normally have bradycardia? If I find out that this patient is altered, they have bradycardia, they have hypotension, and then all of a sudden I find a beta blocker, remember the suffix OLOL, OLOLs, please know that for your National Registry also. You will see some sort of beta blocker type question on that exam. If I find a beta blocker that's empty and I think that it was recently filled, this is when I'm going to suspect that my patient may have taken too many beta blockers. I know there's a lot on this screen next to me. Let's talk a little bit about it. It says, consider atropine sulfate for symptomatic bradycardia. Absolutely, man. We got a patient with symptomatic bradycardia. You know the algorithm for cardiology, right? The American Heart algorithm says, if my patient has symptomatic bradycardia with hemodynamic instability, I should be giving atropine. And atropine works awesome, dude. I gave it my last shift. So a couple of days ago, we had a patient that was just becoming unresponsive. Patient's heart rate was like 40. My first systolic blood pressure that we got on was 70. I gave 1 milligram of atropine and his heart rate went from 40 to 100 with 1 milligram. If this patient was a beta blocker overdose and they took a lot of beta blockers, that atropine wasn't going to do shoot to that patient. Please know that. Don't think that because my patient has a beta blocker overdose that atropine is going to fix it. 100% no. But this is how us as paramedics or EMS providers use it as a diagnostic tool, right? I can go ahead and give 1 milligram of atropine. It's not going to hurt the guy or girl, right? But I can use it initially to see if that's going to increase the rate. If it doesn't work, and now I'm suspecting that, hey, man, there could be some sort of foul play. Let's take a look at this person's medications, and I find a beta blocker bottle that's empty. Look at this. IV glucagon. I did not say IM. IV glucagon is the antidote for beta blocker toxicity. Crazy. IV glucagon, 1 milligram every 5 minutes until your patient either regains consciousness or your patient's heart rate and blood pressure start to come up. Pretty wild to talk about that, because if you've ever seen glucagon, we all know that glucagon comes in that red box that you open up. It's got, I think it's 1 ml, 1 milligram of glucagon is in there. Believe it or not, that little package of glucagon is over $500 per case. And you have to sometimes use over 5 of them to fix beta blocker toxicity. So you need a ton of glucagon. Just remember that. You're going to need a lot more glucagon than you probably carry. So maybe call for additional resources. Taylor's got a question. She says, if test question asks what to give for beta blocker toxicity, and they ask which would you give first, would you still give glucagon first? We confirmed, or the test question confirmed, that it is a beta blocker overdose. The answer is going to be glucagon. So yes, glucagon is the antidote for beta blockers. If you do not know and you're not sure, but your patient's bradycardic, I would say start with atropine. But yes, what you said makes more sense. If they confirm that it is a beta blocker overdose, you're going to pick glucagon. Obviously, it says, and the ED, they can administer a glucagon infusion. We're not doing that in EMS. And we're not going to do much of that. Increased vomiting from glucagon administration. There could be vasopressor infusers such as norepi or dopamine after adequate fluid resuscitation, and cardiac pacing may be required in severe overdose situations. So please don't forget about pressors. Please don't forget about pacing. If your patient is showing signs and symptoms of real unstable, real problems, we can still intervene and give pressors and fluids. Absolutely. Potassium channel blocker toxicity. Now, this is definitely rare. We don't really talk about potassium channel blockers. They are out there. The only reason why I put this in there is because the use of mag sulfate for torsades. So if the patient gets a huge reduction in potassium, they can throw a lethal rhythm called polymorphic VTAC. And if the patient has polymorphic VTAC, which you see here on this photo, IV mag sulfate, 2 grams, is going to be administered to that patient. Polymorphic VTAC is the only cardiac rhythm, if your patient has a pulse, that you will defibrillate. I know that sounds crazy, and most people are going to say, well, if they have a pulse, we're going to synchronize cardiovert. Not for polymorphic VTAC. Because it's twisting of the points, your monitor won't sync to it correctly. We just do what we consider unsynchronized cardioversion, also known as defibrillation. Just like you would for VFib or pulseless VTAC, you're going to do that even if your patient has a pulse. Obviously, this is the unstable treatment for those patients. So they're showing signs and symptoms of shock, they're unresponsive, hemodynamic instability, and they have polymorphic VTAC. We will defibrillate that, which has got to hurt. Calcium channel blockers. This is your diltiazem, your cardizem, right? If your patient is suffering from a calcium channel blocker overdose, it is very similar to a beta blocker overdose. Why do I say that? Your patient's going to have bradycardia, hypotension. Your patient could have the same kind of appearance. They might be unresponsive. It shows here different things that also you're going to see: metabolic acidosis, right? Nausea and vomiting. The treatment for a calcium channel blocker overdose is going to be calcium. Who would have thought? IV calcium chloride. Now, if you remember the dose, it's 500 milligrams to 1 gram of calcium chloride. Also, take a look at this second bullet point. IV glucagon may improve both pulse rate and myocardial contractility. So please don't think that glucagon is only given for beta blocker overdose. You can also give it for calcium channel blockers as well. Again, IV fluids, just like you would with any other patient with hemodynamic instability. All right, digoxin or dig. These patients typically that are on digoxin, they have fast rhythms. They might have a fib. They might have history of some sort of SVT. These patients could have a overdose on their digoxin. Now, the medication that needs to happen is something that you don't carry. Okay, EMS does not carry something called DigiBind. It's digoxin immune fab. This is the definitive treatment for it. But what we can do, supportive care and the consideration of calcium gluconate is something that we can consider. Calcium gluconate is a little bit different than calcium chloride. You're going to hear calcium gluconate get brought up a couple times in this lecture. So calcium gluconate can be considered for dig toxicity. Jumping into organophosphate poisoning. I know everyone wants to yell out, sludge them, right? So salivation, lacrimation, urination, defecation, right? There's a lot of different things that are happening with this patient out of every orifice. These people are leaking. It is absolutely terrible. Chris is saying high dose atropine. Absolutely, right? We'll get into a little bit on how we would treat these patients, but typically organophosphate poisoning was used in World War I, nerve agent, right? Try to kill mass amounts of people. Dumbbells. All right, let's talk about the management of organophosphate. Establish an airway, suction as needed, because remember, they're going to be leaking out of every orifice. So suction and airway management is a big importance here. 1 milligram atropine every 3 to 5 minutes. Again, I'm going to repeat that. 1 milligram of atropine every 3 to 5 minutes until you achieve something called atropinization. I know it's a very strange terminology. Atropinization is when that patient actually stops their signs and symptoms of dumbbells or sledging. 2-PAM auto injectors is another thing that gets brought up. It's kind of like an EpiPen, and they would just go on the lateral thigh, same concept. All right, chlorine gas. Typically, chlorine gas exposures is from pools, okay? I've ran several of these calls. It's when somebody has an accidental spill. The last one I had, the guy did an accidental spill in his garage. Could be at the pool, behind their house, whatever the case might be. If it's dry chem, so it's like some sort of powder, or they use a liquid form of chlorine. The liquid form could get all over their arms and their legs and cause burns. If it is a dry chem, sometimes it like puffs up in their face like a powder and they inhale it. And we can already expect what kind of problems we're going to be able to see here. Burning sensation in the eyes, nose, and throat, coughing. These patients will get rails bilaterally. Remove the patients from the area. Listen to this. Deliver high concentrations of humidified oxygen and nebulized sodium bicarb. This is like crazy medical shit that most people don't even pay attention to in the textbooks. Nebulizing sodium bicarbonate is the antidote for chlorine gas inhalation. Again, move these patients to a safe area, irrigate their eyes and skin if it is on their arms or on their skin, period. If it is in water form, or if it's like a wet chlorine, we're going to just use straight up water and get it off of them. If it is a powder, we're going to brush off the powder first before irrigating it with water. Here's that nebulized. It says you can utilize a CPAP with a nebulizer, 2 mLs of 8.4 solution of sodium bicarb. So that's the adult sodium bicarb box, 8.4%, plus 2 mLs of sterile water. How much water should we technically have in the nebulizer? 4 mLs. 2 of it is bicarb, 2 of it is saline. And we just mix both of them into a nebulizer. And we're flowing that nebulizer again at 6 to 8 liters per minute. And then you can attach that nebulizer to a CPAP. And you can even start that CPAP at 5 PEEP and just flow in that nebulized treatment. Cyanide. This is a good discussion, especially for those of you who are interested in being a firefighter, because cyanide poisoning is something that it affects firefighters because of structure fires, either fighting fire from a vehicle or fighting a structure fire. There's a lot of shit that burns. If you look around in your room right now, your desk is probably not real wood. There's a bunch of, synthetic that's hanging on your walls or whatever. When that stuff burns, it's toxic chemicals such as cyanide. Now let's take a look at the treatment. 100% oxygen via non-rebreather mask or BVM. Our goal right now is to displace cyanide from cytochrome oxidase by introducing another chemical to bind to the cyanide. All we're trying to do is get a chemical that'll bind to the cyanide. Let's take a look. Anticipate hypotension. If the systolic blood pressure falls below 80, consult medical control about giving vasopressors. Take a look here at the bottom. Sodium nitrate, 300 milligrams over 2 minutes. What can happen now is that we can actually cause we can call it an overdose on nitrate. And that's what we're going to look at here. Let's go ahead and take a look down here at the bottom, the last bullet point. Patients that have been treated with sodium nitrate and amyl nitrate are now at risk at developing methylhemoglobinemia. I know, crazy ass terminology. Methylhemoglobinemia is a problem of the hemoglobin. It carries oxygen, right? That's the whole goal of hemoglobin. Did you know that your blood is red because of hemoglobin? If you have methylhemoglobinemia, your blood will turn brown, like a dark brown color. So like, for example, if you start an IV on somebody that has methylhemoglobinemia, you get the flash inside the IV, it'll be dark brown. I have seen methylhemoglobinemia get brought up on tests. Again, how do they get those symptoms? By taking amyl nitrate and sodium nitrate. How do we fix it? Methylene blue. This is a very hazmat type question. Methylene blue is a hazmat medication, but again, it is part of your national. Another medication that you see up here at the top, cyanokit. Okay, that's typically how we call it. We call it a cyanokit. I know there's that hydroxycobalamin, whatever. No, I've never heard anybody else call it that, but it is worded like that in your textbook. The cyanokit is 5 grams over 15 minutes, and it is also given to patients that have suspected cyanide poisoning. Typically, if you find somebody that was in a structure fire and they're unresponsive, you can also give this during a code, by the way. If you're working a cardiac arrest and the patient was coming out of a structure fire, cyanokit is something you can give over 15 minutes during either the code or while that patient is unresponsive. Oh, of course, the next one says used for patients who are hypotensive, altered mental status, or in cardiac arrest following a fire exposure. Absolutely. Cyanokit, man. Don't forget it. How are you guys doing? Okay? You're alive? Now, whenever I think of a caustic, I'm always thinking of that beware sign, something that you pour onto something to degrade it. For example, if you watch Breaking Bad and they would kill somebody, they would use caustics to basically destroy the bodies. Hopefully I'm not giving anybody any ideas. Over here on the side here, we have common caustic substances. It's showing here hydrofluoric acid or hydrochloric acid, sulfuric acid. This is toilet bowl cleaners, battery acid, all this kind of stuff. These are all different acid-based caustics. But what's interesting is we have acids and we have alkalis. Both of them are on different sides of the pH scale, right? So you right now, if you remember, you're 7.35 to 7.45 pH, and that's completely normal for you. But when we look at like a pH scale, 0 to 14, 0, we're looking at extreme acids, and 14, we're looking at extreme alkalis. If you're on either side of this pH scale, these are caustic substances. Like I said, paint remover, all this stuff here on the alkalis, you can take a look at that. You get any of it on your skin, call poison control. Or you get any of it in your eye, you're going to need a lot of flushing. If you have somebody that drank a caustic substance or did anything like that, contact poison control. Remember, 1-800-222-1222. Management. If the patient has severe pain in their mouth, throat, chest, obviously they probably ingested this caustic substance. If respiratory distress is present, could be from swelling of the airway. The patient is in immediate danger of complete airway obstruction. Identify the substance, call poison control. You might have to intubate these patients. If you see any sort of upward airway swelling, be mindful of that. For caustic ingestion, dilution with milk or water is only useful in the minutes immediately following the exposure. So if they just swallowed the caustic substance and you have milk, you can ask that patient to drink the milk. A gastric tube placement is contraindicated. Do not use any sort of gastric lavage. Do not use any sort of substance that you think you're just going to suck out that caustic substance. And definitely do not cause vomiting. If you cause vomiting, that patient just swallowed a caustic substance, And if they vomit, they're going to throw the caustic substance back out and it's going to do double the damage. Big no-no. For dermal exposure, obviously on their skin, dilute and just flush away. Much easier. There's that photo. Caustic substance. Not give any neutralizing substances. Mixing an acid and an alkali can produce heat. So don't think like, oh, he drank an alkali. Let me give him some acidity and it's going to work. It's just going to neutralize it. Doesn't work like that. Don't give activated charcoal either. Call poison control. Methyl alcohol, formaldehyde, and formic acid are responsible for methanol poisoning. Methanol poisoning. It says peak blood levels attained within 90 minutes after ingestion. Symptoms appear 12 to 18 hours after ingestion. That is messed up. Vomiting, headaches, abdominal pain, blurred vision, and even blindness. Patients are going to have dilated pupils, altered mental status, tachypnea, hypotension. Take a look at this management. Sodium bicarb, 1 milliequivalent per kilogram for methyl alcohol. Look at the next treatment. This is always the craziest one. Ethanol can be given. What is ethanol? Ethanol is alcohol. Okay. Typically, they're talking about something that is like more than 70 proof. We're talking like 80 proof. Hardcore alcohol. If the patient has any sort of bottles of really high alcohol concentrations, provide immediate transport. Activated charcoal, again, contraindicated. Don't do it. Get this guy more drunk. That's the goal. And give the sodium bicarb. Ethylene glycol. Here's an interesting one. Antifreeze, coolants, right? Some polishes, paints, different things of that sort. This is known as ethylene glycol overdose. Can be used for alcoholism. If somebody's drinking antifreeze and coolant because they can't afford alcohol, they got some damn problems. But it does happen. Could be a CNS depressant. Hypertension, tachycardia can cause pulmonary edema. That sounds like an awesome way to get drunk. Same treatment as methyl alcohol. Okay. It's the same treatment mean for ethyl alcohol, for methyl alcohol. Let's go back to it real quick, just so you remember this. Sodium bicarb and ethanol. So for ethylene glycol, I can give sodium bicarb, I can give alcohol or ethanol, and I can now give calcium gluconate, 10 mLs. Hydrofluoric acid. Toxicity can be from an extremely small amount. It'll leach calcium and magnesium from the patient's body. That ain't good, right? And systemic effects are primarily related to electrolyte imbalances. Shocking. Inhalation causes throat discomfort, bronchospasming, stridor, airway injury. If they ingest it, vomiting, abdominal pain, gastritis. Doesn't sound fun at all. Take a look at that burn on this guy's fingers. For ingestion, again, consider diluting with milk after the patient ingests it. If it is on their fingers or on their hands, a paste of calcium gluconate is applied. So there is something called calcium gluconate gel. And that's what the National Registry or this textbook is talking about. Calcium gluconate gel, again, 10%, is used to put on the patient's hand, kind of like aloe for a burn, to reduce the symptoms of hydrofluoric acid. Also, the IV administration of 10% calcium gluconate may be allowed by protocol or medical control. TCAs. We're moving on through. Okay, TCAs are known as tricyclic antidepressants. Now take a look at all these antidepressants that I have on here. Amitriptyline, nortriptyline. See how they all end in INE. Please do not think that all suffixes that end in INE are going to be TCAs, because they're not. But if I do see INE, that needs to jump out at me as a provider, and I need to look that up. Is it a calcium channel blocker? Is it going to be a TCA? And if I'm thinking that my patient overdosed on it, we need to know what the signs and symptoms are. Let's take a look. Tachycardia, tachypnea, hypotension, and hyperthermia. Now, typically, these are your patients that are trying to commit suicide that already have history of depression, anxiety. They might have some sort of a psychotic disorder. Antimuscarinic qualities may produce signs and symptoms similar to anticholinergic toxidrome. If you ever heard of the anticholinergic toxidrome, hot as a hair, blind as a bat, dry as a bone, red as a beet, and mad as a hatter, that's talking about somebody who overdoses on anticholinergics such as atropine. These patients, they look very similar with TCA overdoses. Patient can exhibit hyperthermia, dilated pupils, dry skin, red skin, and agitated delirium, agitation and or delirium. Take a look at this EKG here. I know it's like very strange that I would just post AVR, but what it's showing is just some strange QRS complex, right? It's wide, which is abnormal. You're like, okay, I got a wide complex, typically tachycardic. We get a patient that's short of breath. They got dilated pupils. I can see wide complex on the EKG. We have to think TCA overdose. Let's look at the management for TCAs. Manage an airway, give oxygen, administer activated charcoal, and sodium bicarb. Pretty interesting. Sodium bicarb is an antidote that is utilized for TCA overdose. SSRIs used as an antidepressant, right? Selective serotonin reuptake inhibitors says has a larger therapeutic window than MAOIs. MAOIs are also antidepressants. Again, take a look at these names here. I mean, except for Celexa, because we look at Celexa, citalopram. If I ever saw citalopram, which I want to say I have seen this medication because I called it a benzo on scene. I was like, oh, this patient takes benzos because I saw PRAM. And once I looked it up, I was like, it's a SSRI. I didn't expect that because typically when I look at antidepressants, I'm usually looking for INE. It says that it's going to have fewer anticholinergic and cardiac effects than a TCA would. So let's take a look at this assessment. Half of patients may be asymptomatic with SSRI overdoses. When taken with alcohol, we're looking for tachycardia, hypotension, and lethargy. But most commonly, these patients are going to suffer from nausea and vomiting, dysrhythmias. They're going to be sedated and or tremors. Management of these patients with SSRI overdoses. Obviously, we're going to be establishing a line, giving them oxygen if they need it. Consider a single dose of activated charcoal. Treat seizures with benzodiazepines. And if a wide QRS complex occurs, we can then give sodium bicarb. And with that, please note, if you're suspecting a overdose and you're not quite sure what it is, and you start seeing these wide complex tachycardias, if you just see like a wide complex QRS, always suspect that this could be some sort of antidepressant overdose. And don't forget about sodium bicarb, because that bicarb is what's going to help treat the cardiac dysrhythmia. Chemical restraints. A lot of different ways that we can chemically restrain. We talked about some of it earlier, so I'm not going to get too crazy about it. But it's saying diazepam, known as Valium, Ativan, midazolam. What's nice about giving sedatives is that we don't have to use IV, right? We can also give it IM. Just make sure you have a plan for chemical restraint. If your patient gets a little crazy on you and you feel like, hey, man, either the patient's at jeopardy or they're making you feel unsafe or whatever, we always can use chemical restraints. I'm going to be thinking chemical restraints before me using like physical restraints and wrestling with somebody. I have a plan. Some other ones here. Here's that Haldol up here. Remember that 5 milligrams IM. Different ones here that it's talking about says higher doses of IV administration associated higher risk of QT prolongation or torsades with giving Haldol. Administer IV should not be administered to patients younger than 14 years of age or that have head injuries or those who are pregnant. These are all antipsychotics that they're talking about. Antihistamine, we talked about Benadryl and how it's used for sedation. It causes drowsiness. If you are using a antipsychotic, again, we can go ahead and give Benadryl along with it to reduce dystonia. Food poisoning. I'm sure everyone here has experienced food poisoning sometime in their life. It sucks. I don't recommend it. If you haven't tried it, don't do it. But if you are going to have food poisoning, or if you're treating a patient with food poisoning, expect nausea, vomiting, diarrhea, fevers. If the patient has hypotension due to fluid loss, they are now in hypovolemic shock. Okay, typically if I have elderly patients or pediatric patients with food poisoning, always suspect hypovolemic shock. Treatment, IV fluids and antiemetics. Antiemetics are something like Zofran, 4 milligrams that you can consider, IV or IM. Look at this one though at the bottom. If patient has facial flushing, administer Benadryl to a patient with food poisoning. So the last group of slides that I'm going to go over are all endocrine. With endocrine emergencies, because these confuse people like crazy, I'm not going to talk about diabetes. Okay. Just because I can talk about diabetes for like over an hour, and I'm not going to do that to you. First one, adrenal insufficiency. When we talk about your adrenal glands are on top of your kidneys. What do your adrenal glands create? Hormones, right? We're talking about the endocrine system. So whenever we talk about the endocrine system, I always want you to think hormones. Remember, your hormones get transported throughout your body via your blood. And the two that are being created here are aldosterone and cortisol. Cortisol plays a very important role. Okay. Cortisol's primary role is to assist your body's response to stress. Now, I know you're probably thinking, well, with stress, you have the sympathetic nervous system, your heart rate increases and all these things happen. But let's take a look at what cortisol does. It will maintain your blood pressure and cardiac function. It will regulate your metabolism of carbohydrates, proteins, and fats, can modulate glucose and insulin, and it can even slow down your inflammatory response. If you have an insufficiency of your adrenal gland, this is known as Addison's disease. I've also heard it being called Addisonian crisis or Addison's crisis, but Addison's disease is adrenal insufficiency. Look at some of these signs and symptoms that you're going to see in your patient. And take a look at the photo. We have two different hands that are being shown. One has like a really like dark complexion or pigmentation that you see on the right-hand side, often seen with endocrine disorders. And I'm sure you've seen some of these patients. Some signs and symptoms: unexplained weight loss, fatigue, vomiting, diarrhea, anorexia, salt cravings. That's a weird one. But this increased pigmentation, right, on the surface, there's palmar creases and oral mucosa around their mouth. Very strange signs and symptoms. And whenever we talk about signs and symptoms of the endocrine system, they often get misdiagnosed, which is unfortunate because they're so like odd. They like unexplained weight loss and diarrhea. Some people are going to say that this is, it's probably from food poisoning or whatever, but it could be an endocrine disorder. Management, kind of strange. Hydrocortisone. So you actually give a steroid for it, 100 milligrams IV for acute management and or crisis. Now, typically us as EMS, we're not doing no damn like, I think you have Addison's disease. Let's go ahead. We're going to go ahead and give you some hydrocortisone. No, man, we don't treat these patients as if like we're diagnosing them with Addison's disease. If you carry hydrocortisone, you're giving it to this patient because they tell you that they have Addison's disease, and now they're suffering from all these signs and symptoms. That's why. Jay asks, is cortisol and aldosterone similar? Well, they're coming from the same organ, right? They're coming from your adrenal glands. But I would imagine aldosterone has some different properties to it. I'm not 100% sure, so I don't want to give you like wrong information. What I do want you to remember is that your adrenal glands use these two. If you have an insufficiency, you're going to have a decrease in both aldosterone and cortisol. The reason why cortisol gets brought up a lot when we talk about these disease processes is because not only Addison's has all those signs and symptoms because of a decrease in cortisol, but then look at Cushing syndrome. What is Cushing syndrome? It's an excess of cortisol. So now let's say that you have a tumor on your kidney or around that area, and it's pushing up against your adrenal gland, and it's causing an overproduction of cortisol. This excess of cortisol production on your adrenal glands causes something called Cushing's syndrome. And look at this woman in this diagram. There's several things that start to change on these people. One of them is known as a buffalo hump. I know that sounds really messed up to say that somebody has a buffalo hump, but it is literally a large mass starts to grow on the back of their neck. Another one, they start to get really large. They get an increased weight gain. Another thing you're going to note is something called moon face. God, these names, man, they're messed up. Moon face, literally the patient's face starts to round out. They get a lot more like fat excess on their face. Blood glucose levels will rise. Okay, protein synthesis becomes impaired. So the patient has like a difficult time breaking down foods and things of that sort. Bones will start to become weaker. The patient becomes fatigued. increased thirst and urination, massive weight gain. And again, look at this thinning and darkening of the skin. So the adrenal glands has a big to do with your pigmentation of your skin. And take a look at that word, acanthosis. Acanthosis means the thinning and darkening of pigmentation of your skin. So both either Addison's disease and or Cushing's syndrome, both have acanthosis. Look at that buffalo hump. That's just crazy. Okay. Treatment is supportive. Now let's take a look at this hypothyroidism versus hyperthyroidism, because there's a lot of different kind of like disorders. I know Jay brought up Hashimoto's, there's thyroid storm, myxedema coma, Graves' disease, right? There's a lot of different names that get thrown around with hyper or hypothyroidism. Now, obviously, they're opposites of each other. So let's take a look at cardiac effects on the top. If it's hypothyroidism, they have a slow pulse. With hyperthyroidism, they have a fast pulse. Metabolic effects. If it's hypo, they have a decrease in metabolism, hence why they have an increase in weight gain. If it is hyperthyroidism, they have an increase in metabolism. They actually lose weight. Neuromuscular effects, they become weak, sluggish with hypo. They get tremors and hyperactive with hyper. So there's a lot of like yin and yang when we talk about hypo versus hyperthyroidism. Again, easily misdiagnosed, man. And I feel really bad for the people that have to deal with these kind of endocrine disorders. Because you look at something like hypothyroidism, anybody could have it. A lot of people, they get called lazy. They get really overweight. They never want to go outside. They don't work out, and people just think like, oh man, they don't want to do anything. They don't want to fix their weight. They don't want to exercise, whatever. It could just be a legit endocrine disorder. The most common hyperthyroid disease is known as Graves' disease. 10 times more common in women. The only person that I always think about when I hear Graves' disease is Wendy Williams on daytime TV. You know what I'm talking about? Wendy Williams, she has like these crazy eyes, and she's been like very open about talking about Graves' disease. But typically when somebody has Graves' disease, they become like hyperactive. They can't sleep, thirsty, they're always moving around, crazy amount of weight loss. And their eyes literally will bulge out of their face, which is crazy to see. But look up some photos on Google when you get a chance of Graves' disease, and you'll see what I'm talking about. God bless Wendy Williams. Hope she gets better. Myxedema coma, the exact opposite. Okay, so look at patients that have hyperthyroidism and their thyroid's overstimulated. Again, typically that's from like a tumor on the thyroid. With myxedema coma, this patient has hypothyroidism, and they become super fatigued to the point where these people are literally in a coma. What's crazy, man, look at the second bullet point here that I put. Often presents with an accumulation of mucinous material on the skin. What the hell does that mean? What it means is the patient has like a wax appearance on their skin. So their skin is like literally glistening in the light. They have like this film on top of them, and everything is slowed, right? Their metabolism slowed. Their skin it becomes super dry in appearance. I'm going to show you a photo here of somebody with myxedema coma. They'll literally be unresponsive and hypothermic. So super cold to the touch. Take a look at this photo. On the right is when she was normal. On the left is myxedema coma. Brutal. Okay. And you can see how like dried out her skin got, the swelling in her face. Terrible, man. Absolutely terrible. Supplemental oxygen, if they're hypoxic. Intubation and ventilation is definitely indicated for these patients because they're unable to protect their own airway. Passive rewarming, because again, these patients are going to be hypothermic. It says avoid sedatives, narcotics, and anesthetics. Avoid using them. These patients are unresponsive. I would imagine the reason why you would avoid using them is because the patient, everything is so slowed down already on the patient. Giving more sedatives or more downers can actually cause probably bradycardia, more hypotension. It's going to have some other adverse effects that you do not want. And with that, does anyone have any questions about any of these medical managements? I know it was a lot. I hope this helped talking about different managements for different medical disorders. Just remember, When we talk about medical, because medical is a section in the National Registry, there's a wide variety of different things that they can choose from. Put a little time into knowing medical. Not only is there signs and symptoms, but there's also treatments that are involved. And also you got to think about, how are my vital signs going to change? So if the National Registry gives you a question that is a scenario-based question, can you tell by just looking at an EKG and some vital signs that this patient possibly had a TCA overdose? Well, yeah, you can. As long as you know, I'm looking for wide QRS complexes. I'm looking for prolonged QT intervals. I'm looking for hypotension, tachypnea, right? Unresponsive. You're looking for certain things. If you don't know the signs and symptoms of the medical emergencies, you're going to have a really tough time with the medical portion.
Medical can be the paramedic killer on the National Registry. I know last time I mentioned about my book, look how much is talking about medical. It's crazy. I did mention something in that lecture on the information that you need for medical is going to be, what is it? What are the signs and symptoms? And how do we treat it? That's exactly the type of information that I'm going over. So for those of you who are interested in the book, it's coming out this month and I'm extremely excited about it. And I also want to announce that I'm opening an online community page. Now, this community page is not only going to be for students to talk to other students, but talk to me and other people in the field that can help you out, answering questions and just having a discussion about EMS topics. Another thing I'm going to be posting there is weekly EMS news, job postings in EMS around the country. Oh man, it's a lot of work, but I'm going to have a ton of test questions on there. Now, I'm really excited for this step for Rescue Academy, and I'm hoping to see you all there. Let me know down in the comments if you have any recommendations or anything that you want to see done, maybe in the community, maybe in future videos. I'm here for you. See you on the next one.